Welcome to the Redefine Health Ed podcast. I'm your host, Dr. Katie Obright, and we're going to talk all things primary care PT. Hello, everybody. This is episode 8 of the Redefine Health Ed podcast primary care series. And today I have one of my friends and colleagues, Dr. Rebekah Griffith, with me today. Rebekah is the ED DPT and specializes in care in the emergency department. She also just published a book, which we'll talk about. Dr. Griffith believes physical therapist practice in the emergency department is a critical way to move upstream in healthcare that supports patients during their most critical moments. Totally true. Dr. Griffith has been an invited lecturer, presenter, podcast guest, and article contributor on this topic. Additionally, she was instrumental in passing 2 motions within the APTA House of Delegates in support of emergency physical therapist practice, and is a founding member of the Emergency PT Steering Committee within the Academy of Acute Care. The ED DPT will prepare you to be successfully practice in the emergency department so that patients have access to the right provider at a critical moment in their healthcare journey. Rebekah, thanks so much for joining us today.
Oh, thanks for having me. I'm so excited to be here.
So we were just chit-chatting before we got on this, and really I just kind of want to catch up and hear about some of the stuff that you've been doing lately, like that cool book that you just happened to write in, I don't know, less than a year and plop on Amazon. Tell us a little bit more about that.
Okay, so I don't know, probably in April of last year, I decided that I would start this business. And the goal of the business is for emergency department physical therapists to be well known and for the practice to be well practiced. So kind of, I think you and I have a similar mission in that you want primary care to be well practiced and you want physical therapists to be at the top of their scope. So I absolutely want the same thing, just really specifically in the emergency department. So as trying to promote that, there are several things I've been doing. And one of them was to write a book about how to do it. And so I just kind of started working on that last April. And then, I've got kids, so I had to take the summer off and I'm in a fellowship program. So those two things did not mix well. So then in the fall, I really tried to work on it a little bit at a time until it got done. And then literally somebody bet me I couldn't have it done by CSM. And so I was going to have to buy somebody a really nice dinner if I didn't finish it. So I was like, January, it'll be ready to go. So there we are. Here we are.
So for those of you who are listening and not watching, my face right now, I'm just giggling because I'm just like this. You're insane. You're actually insane, but insanely amazing. So fellowship, and you have 4 kids? 3?
Four right now. I have 3 of my own kids, and then we have an exchange student this year.
Oh my gosh, that is so awesome.
It's the coolest thing. I'm not sure what I was thinking. I don't know why I thought having an extra kid wouldn't be hard, but it's harder to just have a 4th kid, but it's been a great experience.
Okay, so fellowship.
Yeah.
4 kids currently.
Yeah.
You work in the emergency department.
Yes.
And then you started this business and wrote a book in less than 1 year.
Yes.
Yeah. Unbelievable.
I know. I'm having some trouble wrapping my head around it as well. I don't know what to say. I just really wanted to do it.
And I understand that. I totally get that. And I think, so from a primary care perspective, I mean, you and I have followed kind of pretty similar journeys. And, the bottom line with what I'm trying to do with expanding PTs in primary care practice, not just in co-located practice, but having, and Seth Peterson in the last episode so eloquently put this, primary care is a philosophy of practice. It's not just a setting. It's not just a thing. It is a philosophy and a mindset of practice. So we are both kind of trying to do very similar things, me in the primary care space and you in the ED space. So I think that it's important to, for us to really define what each of those things are, because a lot of times the ED type practice, is sometimes used interchangeably with primary care. I think that
Yeah,
there's some overlap, but I also think there's some really distinct differences. So
I
I would
agree.
love to hear in your words how you define those two things and what ED practice really looks like compared to primary care.
Yeah, so I would agree with Dr. Peterson in that one thing we talk about in our course to help people start a physical therapist practice in the ED is mindset. And are you of the mindset that you're a consultant, or are you the mindset that you're a primary provider? And either is fine, right? And then we give you the skill set to practice in either of those two different ways. But for me, the emergency department really differs from primary care in that it is a different moment in that patient's life. Primary care really is so comprehensive and really focuses on like the overall like wellness of that patient. Correct me if I'm wrong,
Mhm.
but emergency care is like we have a problem and we need to stabilize that problem. So I think of us more like the bomb squad kind of, that we have that we have like that primary care mindset, right? Where we're bringing those tools in with us, but then
Mhm.
we're applying those familiar tools in unfamiliar ways to stabilize a crisis
Mhm.
and then get that person back to that primary care PT.
Mhm.
So
Yeah.
so I have patients who come in from their physical therapist for whatever reason. Like yesterday I had a patient who saw their primary care doctor in the morning, got injections, then went to physical therapy, and then the combination of those two things was like so aggravating to this person that they then went to the emergency department where they saw a physical therapist. So, in that moment, like my job was to stabilize the incident that was happening to her in that moment. Because for whatever reason, the physical therapist who primarily manages her felt like they couldn't manage what was happening. So I was using my specialty skills to manage that situation, set her up for success, and to be able to go back out and have those same resources. And
Mhm.
when I can, I try to communicate with that primary care PT just like you would an emergency department send records to your primary care physician. So I
Mhm.
think we use those same tools, but we just have a different goal. And ours is a very short-term goal.
Mhm. Yeah, so I think that in primary care PT, and I am trying my best to um, get more the definition of primary care PT more clearly defined, because I think
Mhm.
a lot of people use it synonymously with just direct access. Oh, you're
Yeah.
seeing a patient, direct access, and therefore you're a primary care PT. That is, I just want to lay it out there that, and I've said this before and I'll say it forever, that is not the case. Direct
Shaking your head
direct
no
access just means
vigorously.
direct access just means that you can see a patient without a referral. That
Agree.
has no bearing on your philosophy of the way that you care for a patient, the way that you evaluate a patient.
Yes.
Primary care PT is really about in that first visit with a patient, if you've never seen them before, you don't know them, you don't know anything about them, you need to get a full picture of what that patient's life is like from a lot of different angles, from
Yes.
socioeconomic, from their lifestyle behaviors, their past medical history, and really understanding how everything in their past medical history, whether it's related to the complaint that they come to you with or not, might be related to their problem, their global health picture, their cardiovascular risk profile, all of those
Yes.
things.
Mhm.
And then you're taking that information from day one and building it into a care plan for that patient over time, and then also
Yes.
having a sustainable relationship with that patient, just like you would a primary care physician. So I'm curious, because we just had a course in Salt Lake City this past weekend, which was awesome, very engaging, very interesting. Everybody just brought up these amazing discussion points. But one thing that kept happening, or one thing that we kept talking about was, because day one of my course, we really talk about what pathologies are really important to be screened, ASAP, urgently, or
Yeah.
emergently, and what cases are appropriate for the emergency department setting.
Mhm.
And some of the cases that we talked about, the recommendations are, critical medical. This needs to be evaluated emergently, and the resources that are available by the emergency department, like it can't be handled in urgent care type thing.
Right. Mhm.
But some of the feedback that I've gotten, I've experienced this myself, is sometimes patients that we send to the emergency department because we feel that's the right thing to do,
Yes.
they come back from the emergency department and they say, They didn't do
No.
anything for me. Nothing
Yeah.
happened. So
Yes.
I would love to hear your perspective on that and how, maybe the issues with that, how physical therapists and primary care PTs can do better in referring patients to ED. And then, maybe, I don't know, just talk about it.
Yeah, so that happens a lot. And one of the things that I had to learn in the emergency department is like all of the parameters that we learned in PT school. Like this is a red flag and this is super dangerous and you can't mobilize a patient with numbers like this.
Mhm.
All of that goes out the window in the emergency department. Like
Right.
I'll be like their blood pressure is 210 over 180 and they're like, "Yeah." And I'm like, well, I don't want to mobilize that patient. They're like, why not? They came in here like that. They live like that. What's the problem? And I'm like, I don't know. Just like they're at a high risk of stroke. Like that's like a bad thing. What if something happens while I'm mobilizing them? And they're like, great, then we'll have more information. So it's definitely more like, it's a little bit more like Fight Club. Like there are no rules, right? You just do it. And so my risk tolerance is so much higher. If your blood pressure is through the roof, I'm still going to mobilize you because they aren't going to manage that blood pressure and they're going to send you back home like that. So
Uh-huh.
I feel like it's my job if to get you up and moving and push your functional mobility and kind of see what happens a little bit safely, right? I'm monitoring them that whole time. But then I can tell the physicians like, "Hey, their blood pressure's here." And when they go up and down the stairs, they have blurry vision, they are tachycardic, or their
Mhm.
pulse ox is dropping. And then they have more information. So we're actually more part of that diagnostic workup.
Mhm.
So whenever a PT sends a patient to the emergency department for elevated blood pressure, the team is like, what? Like, why are we wasting these resources? So
Mhm.
there are things like that where I would definitely say there should be steps between PT and the emergency department. And like DVT, probably not an emergency that you necessarily need to send somebody directly to the emergency department for, based on my experience. I'm not saying this is based on clinical evidence. I'm not saying
Yeah.
this is based on best practice. I'm just saying, like, based on my experience, they will screen the patients for a DVT, but they're going to be like last on that priority list. And if they can do that through their outpatient facility, like through an imaging center, like if you
Mhm.
have the imaging rights, if you can refer that patient for an ultrasound for the DVT yourself,
Mhm.
that might be more effective than sending them to the ED to wait for several hours.
Mhm.
So those are some of the things that I find are a bigger issue. Also, this concept of 10 out of 10 pain.
Mhm.
That does not need to go to the emergency room really, like because you know what, they're going to give them very expensive Tylenol, a very expensive ibuprofen, and a very expensive lidocaine patch.
Mhm.
So, and then they're going to refer that patient to me. So,
Mhm.
if you can work with those patients who have 10 out of 10 pain, unless there's like some real red flag, like you
Mhm.
think this is actually an aortic aneurysm or something like that, please work with that patient. Don't be
Mhm.
afraid to like get in there with that highly acute and sensitive reactive pain because they're going to be very disappointed if they go to the ED and get ibuprofen.
Oh my gosh, I am so glad that you brought up those 2 things. Let's talk
Tell
about
me.
DVTs. So,
Yeah.
in every clinical practice guideline and every little bit of information that you get from educators is that DVTs go to the emergency department. In
PEs,
my
yes.
in my experience in my experience, the patients that I have referred, that have had DVTs, great. They start on Eliquis. Like, I
Yep.
know in sending them that two of the cases were from when I was active duty where I ordered and placed those ultrasounds myself. They had DVTs and I send them to the emergency department because they have a DVT when really I could have just talked to the primary care providers that I was with and they
Yes.
probably could have just started them on Eliquis right then and there. But even some of the primary care physicians were like not comfortable with that. So there's such a like wide
But
variety. There's
is
so much
but
variability.
but is a DVT an emergency? So when we talk to PT students about it, we are now like, is this an emergency or is this something that needs follow up? I think it needs follow up. If a patient
Mhm.
has signs and symptoms of a PE, please send them to the emergency department and
Uh-huh.
not by private vehicle, preferably.
Yeah.
Because that's the other thing I see is that as patients will say, well, the PT told me I needed to come to the emergency department. And I'm like, well, why? Well, they were really concerned about my shortness of breath. And I'm like, why didn't they call an ambulance? Like, if you feel like that patient is unstable enough that they need to go directly to the emergency department, please don't have them drive themselves.
Mhm.
Because if you think that patient has a PE and they arrest on the way, that's not good for you. So
Mhm.
I would monitor like why you're sending them. If you feel comfortable sending them in a vehicle, that's fine. If the patient refuses, you calling EMS, also fine. But make sure you're like managing that perspective as well. If you really think this
Okay,
patient has a PE,
love this information because also in the outpatient setting, not in the military, I had a patient come in. She was 1 week post-op. She was in her 60s, but very fit,
yes,
and I wouldn't have expected it. She came in, short of breath, rapid pulse, high blood pressure, and she was like borderline diaphoretic. I was like, "We gotta go. You gotta
yeah,
go." And she refused me calling an ambulance. So I was like, okay, how close is someone that can drive you? Can we like figure this out so that you are not driving yourself or something?
yeah,
And then so she called her husband came and got her within a couple of minutes and then they went to the ED. She almost didn't believe me. Like
yeah.
she was like, "No, I'm not paying an ambulance bill. Don't
I,
do,
and I get
if
that.
you call 911, I'm not going." And she was, coherent enough to tell me all of this. So I was like, all right, what other options? So is that a reasonable alternative, do you think?
Well, I think the other thing, what I have done in when I've been in outpatient practice, is I will still call the paramedics. Whether the patient goes with them or not is up to the patient and the paramedics. But I have at least gotten the emergency medical system to evaluate that patient at that point of care. So
Okay. What
that
would that look like for me? So I'm calling 911 and I'm on the phone with them. Like,
Yeah,
tell me
and
how that would look like.
so what I've done in the past is, as you know, I've called and I said I have a patient here whose blood pressure is 70/30. They're tachycardic. I'm really concerned about them, and I don't think we can get the patient safely to the emergency department at this time. The EMS can come. They can do EKG. They can apply oxygen, assess vitals. They can use their emergency medical experience to make a decision. Oftentimes, when patients are like, "Oh, this must be serious," the paramedics are here,
Mhm.
they might take it a little bit more seriously, but you can always say no. Like, you never have to go with them.
Mhm.
You can always say no, and they may call into the hospital. You might have to refuse transport to an attending physician, but then
Mhm.
you're also hearing from an attending physician who's heard that information about you, and
Mhm.
you can make that decision. So you
Mhm.
can always refuse transport, and you don't pay for anything until you get into the ambulance.
Mhm.
In general, I mean, if they use supplies, you might have to, but usually I prefer to have, if I'm really concerned about somebody, like really, and the other issue is, do they have questionable decision making in that moment?
Mhm. Right.
So my preference is to get that EMS crew there and get another set of eyes on them, and have them make a decision about whether or not that patient should go. And then the patient has been at least evaluated by emergency personnel. Now,
Mhm.
I mean, I know not everybody's 100% comfortable with that. If you're in a primary care model where you're have a whole team with you, which I have also done, that's better, right? Because I can call the nurse. I had a patient with Parkinson's on a treadmill once who was having some really terrible vital instability. The cardiologist just popped down from a floor up and took a look at
Mm.
him and was like, "Oh
Mhm.
no, it's just fine." But if you're on your own, I think it's hard for you to make a comfortable decision sending people by private vehicle if you're really
Mhm.
concerned for an emergent process.
This is so stinking helpful, and I just am wondering, like, why do you so if we know and you also brought up this case of, like, critical value, and I'm for those who are not watching me, I'm using my air quotes, "critical, blood pressure." So let's say you've
Hmm.
got a patient that's, I don't know, 200 over 115, and
Yeah.
that's not typical for them, that's not normal. I did have guidance from a cardiologist that I work with, Dr. Jim Comezzo, who gave me some very specific guidelines on like if a patient is young and doesn't have any issues, if a patient
Hmm.
is not young and not medicated, and it's unstable, so he gave me very specific guidelines to follow, and I outlined that in my course. But we always learn if somebody has this critical blood pressure that it looks, on the AHA guidelines, it even says that it's critical.
Yeah.
So, but when I got from the army to the cancer center, we had patients with unstable high or like, weird blood pressure that kind of went high, then it went low. And then we would
Hmm.
get them moving on the treadmill. and their blood pressure and their heart rate sometimes would actually start to stabilize.
Yep.
So we would actually recommend doing that if we had a patient with hypertension, get them moving, get them up on a treadmill,
Yes.
see if their vitals actually start to stabilize against a little bit of workload. And I feel like that is just which it challenged me in such a good way, but I
Hmm.
feel like that's going against everything that we're ever taught. So
Yes.
if these things are not considered emergent that need ED care, why do we learn it like that? And what do you think needs to happen with the way that we're educated?
I think there's just such a disconnect between like the clinic setting and the emergency department setting. It really is like Edward Norton and Brad Pitt, right? Like they're just totally different settings. And I think we are taught to be cautious because we don't want to harm our patients. And
Mhm.
are we doing harm exercising somebody with a really elevated blood pressure? Maybe we are. But most of the patients that we see in the emergency department, they either have blood pressure medication but aren't taking it, or they've been prescribed but they don't have an ability to pay for it. So usually the concept is unless they're actually in some kind of hypertensive crisis,
Mhm.
the emergency department's not really going to do anything other than refer that patient back to their primary care physician to have that managed.
Mhm.
So unless there's actually something else that's going along with it, I think that's where the concern is. But I think we are taught the way we are because it hasn't been considered in our scope to make that decision
Mhm.
about whether it's an emergency or not. And I
Mhm.
totally respect that. But I think we need to, as physical therapists, look at that whole picture.
Mhm.
Do we check vitals every single time this patient comes in?
Mhm.
Because blood pressure is a measurement over time, right? Like one blood pressure measurement doesn't give you anything.
Yes.
It, I check patients' blood pressure maybe 3 times. It might be wildly different each time. So
Mhm.
if you're seeing these patients, you should know their trends.
Mhm.
That being said,
Absolutely.
if somebody comes in the very first time and their blood pressure's through the roof, I would still probably take a history and take a little time and see if they're just nervous and then check it
Mhm.
again
That
and
is
see how that
exactly
goes.
yes, that is exactly what Dr. Kometso recommended. He was like, blood pressure is one of those things where you could catch it at its peak, and
Yep.
that doesn't mean that they're in a crisis, especially if
Yes.
there's no other signs or symptoms of instability,
Yes.
vital instability. So he actually recommended go through your whole treatment session,
And
and
see how
then,
they are.
have them lay down for 10 minutes at the end, turn the lights out, take their blood pressure again. He was like,
Yes.
"It's probably going to be lower." Because what happens is, like, I have referred patients to the ED, with that crazy, crazy, crazy high blood pressure, and then at the ED, I see their records, and at the
It's like
ED, it's
130
like
over 90.
exactly.
Yeah.
And so he was like, "That probably is, waste of resources," and I
Especially
totally
right
agree with
now.
that. I especially right now, and again, patients, we have to think about the socioeconomic
Yes.
things associated with this. Patients don't wanna go to the ED because it takes fricking forever to get
And
seen,
it's so
and it's
expensive.
so expensive,
I am the
so
most expensive
expensive.
PT visit. Like, I'm the most expensive physical therapist ever because
Mhm,
even though I'm billing the same CPT codes everyone
mhm,
else is,
mhm.
they're still paying for the entire overhead of the emergency department.
Right. Yeah.
So I think too, like you have to know your patients. If you don't know them, I find that after I establish therapeutic alliance with a patient in their room, their blood pressure drops because they're nervous, they're upset, they're scared.
They're in
Something's going on
pain.
with them. Yes.
Yeah.
And frankly, half the time I would rather have high blood pressure than those people who come in on a little bit on the low side. And then I get them
Uh-huh.
up and they're like, so I don't know. I think that's one of those things where my risk tolerance is much higher. And I had
Yeah.
somebody say to me, well, that's because you have a code card outside the room. And that's not false. I have an entire team of people there.
Mhm,
But my goal is not to harm the patient. My
mhm,
goal is to help with that diagnostic workup, help with their function. Are
mhm,
they functioning at this blood pressure? And then
mhm,
provide education to them about that blood pressure. Hey, like your blood pressure is really high. What is it normally? And
mhm,
that is such a great opportunity to do that upstream piece where we're trying to get ahead of a patient's problem before that hypertensive issue becomes a crisis
mhm. Yes,
and have that
absolutely.
conversation with them. And the House of Delegates this last year passed that motion about physical therapists in the non-pharmacologic management of the high blood pressure.
Yes, I was so
And
happy about that.
and I am here for that. So I'm going to have that conversation with people, especially people who are in that the bottom of that safety net. the
Mhm.
ones who don't have health insurance, the ones who will never see a physical therapist anywhere else because PT is a luxury. Like, let's face
Mhm.
it, it's a luxury for people. People who eat what they can eat. Like, it's very hard for me to talk to somebody about a low sodium diet if all they can eat
That's
is
all that they have
what they
access
have
to.
access to.
Right.
So I think it's just a completely different way of practicing in this setting.
Yeah. Oh my gosh. So I have a question for you. So from a physical therapist perspective, and now like you are also a neuro specialist and you're in an
Mhm.
ortho fellowship.
Yeah.
So you pretty much have this kind of like multi-specialty practice. I'm curious, what things that would present in an outpatient environment or even in home health would you say actually need to go to the ED as
Mm.
opposed to being managed in an outpatient, maybe like an ASAP same day call to a primary care to a cardiologist, what stuff actually does need to go to the ED?
Altered mental status.
Okay.
I mean, I just don't think that's one you want to mess around with. There are so many
Absolutely.
reasons for that, particularly in your vulnerable populations in home health, like altered mental status. I don't love that.
Yeah.
I think also any like signs symptoms of stroke. Like, I'd
Mhm.
rather you be wrong and send them than not send them. I also think we need a different approach to red flags because so many patients come in with red flags, but like when we dig a little deeper, they're not red flags. They're like, I can get why people think that. Had a patient who had a joint tapped for possible septic joint based on the way she gave the history. But when I spoke to the patient, it was like, well, no, I started a new exercise program at the beginning of the year and my shoulder's been bothering me for a month. But
Mhm.
what she had reported to the person who was seeing her was, I woke up with insidious 10 out of 10 pain in this shoulder joint, like
Mhm.
no provoking factors. But like with a little bit more information, like clearly it had been a progressive issue due to a very musculoskeletal cause.
Yeah, so not jumping to conclusions and making sure you're
Yes.
doing a really thorough investigation if somebody is reporting something like that. That's a great point.
Also are like non-traditional red flags. The number
Mhm.
of like spinal abscesses that I've seen is crazy. And they present very much like radicular back pain. And it's the not traditional things that you're hearing from patients. They might be a little tachycardic. They might tell you that have a little bit of brain fog. They might say like, my function just feels like it's been declining, or I've had back pain in the past, but this is just not the same.
Right.
And like I also think we just kind of gloss over that sometimes because it looks like it should, and it
Uh-huh.
isn't a traditional red flag.
Yeah, so
So
I think that like you kind of hit it when you said, looking to see if they're a little bit tachycardic, which is why it is so important that we understand patients' baseline vitals and kind of what their
yes,
vitals look like
please.
over a period of time. And
Hmm.
the vast majority of outpatient and home health therapists are not taking vitals. The vast majority. And
Yeah.
it crushes my soul because
Yes.
that I think is really one of the roots to see or the what's the word I'm looking for? It's one of the primary ways that we can see if a patient is becoming a little unstable or if there is something a little deeper going on. In fact, that that paper that I just reviewed last month, it was the new vascular considerations for individuals with neck pain. Did you see
Hmm.
that?
Yes.
So it just came out ahead of print from JOSPT, and the basically the three things that it said that we should do is everything that we should be doing kind of all the time. Taking vitals, and if the
Yep.
vitals are unstable, auscultating, looking at the carotid arteries, palpating and seeing if there's a difference between the carotid arteries, auscultating, doing your cranial nerve exam. Those are the
Yep.
things that are actually more likely to be associated with these, dissection and non-dissection vascular
Yes.
events in the cervical spine. But I think it was just highly debated before, and we were taught these positional holds that are mostly garbage. So I'm curious about, so you said altered mental status, signs and symptoms of stroke, and then spinal abscesses. It's really interesting that you're saying that you've seen a lot of those because
Hmm.
in the literature, the prevalence of that in first world countries, I hate using that term. Not in developing countries, I suppose, which I hate saying that too. It just doesn't make
Yeah.
sense to me. Um, but
overly
the
highly
prevalence is so
medicalized
low,
countries.
like
It
0.0001%
is,
of all
yeah.
back pain. So I'm curious about that. Are these mostly like post-surgical patients?
No. I have a case study on a patient who it really was like a septic emboli from an intestinal issue. Like
Oh
another,
my.
sometimes it's IV drug use. Sometimes it just, there's no reason.
Mm,
And I've been surprised every time. And when I say a lot, I mean like maybe 8 in the course of like 8 years, like maybe 1 a year. I see far more people coming in with adverse events from a chiropractor than I do seeing a spinal abscess. But it's a thing that I think like your spidey senses need to be aware of when
mhm,
you're looking at differential diagnosis for patients. And
mhm.
when you talk about like checking vitals, I would tell you that my hot take is like if you're not doing that and you're mobilizing patients, it's negligent.
I'm with you. I'm
A-
with
And
you
if
so
you
much.
and the number one thing, if I'm with a patient and something happens and then I check their vitals and their vitals are trash, the number one thing the team says to me is, what was it when you started?
Yeah, what was the
If I
baseline?
don't know, one, why am I exercising a patient who I don't know if their vitals are stable? I don't care what setting you're in. And
Mhm,
two, like that doesn't help them. There's a
mhm,
problem now, but like, was the problem my fault? Was this something that is an ongoing condition for them?
mhm,
Also, like, how do you do differential diagnosis
mhm.
without monitoring vitals? Like, I don't understand that.
We
So,
don't either. We are on the same page, you and I, but I do think that there is, um, I hope that it's getting better, but I do think there's across the board a lack of emphasis on it. And I think I mentioned this in the last podcast that I did with Seth, but I'm the recipient of three like pretty big orthopedic surgeries over the past 4 years. And unfortunately, my therapists were good, but unfortunately, not a single therapist took my vitals
okay,
in
my
that post-operative
dentist takes my
stays.
vitals.
I know.
My dentist takes my vitals. I had a friend who had their preeclampsia diagnosed by their dentist.
Mhm. Absolutely, because I mean, how much like, I mean, that makes perfect sense because, a lot of weird stuff happens in the orofacial region. A lot of weird stuff
Well, and
happens there.
anxiety too for
Yeah.
people like not me. I mean,
Man.
totally me. I'm got the worst dental anxiety ever. So obviously my blood pressure is always through the roof at the dentist, but
Uh-huh.
it's fine at my primary care doctor, which is again a way of showing you the trends matter. The
Yeah,
situation
absolutely.
matters.
Okay, any other things that we see in the outpatient or home health setting that we should be considering an emergency department referral as opposed to a same day. So I'm here. So just to review, altered mental status, signs and symptoms of a possible stroke, any signs or symptoms of like a possible infection, which can be subtle. And that's why it's important to know your patient and know their vitals. Anything else?
I would say signs of sepsis, right? Like any
Mhm,
signs of sepsis, you want to get on that right away. Obviously, any signs, symptoms of heart attack are very important. Um, the other like unpopular thing maybe that I'm going to say is mental health problems. We need to be monitoring our patients and their mental health, especially in the home health setting, especially right now, because those patients may not see anybody else
mhm,
and they may be very isolated. And if you have patients that are really struggling with a mental health problem, I don't know that we're really the best people to manage that.
mhm,
And they may need to come in for their own safety. So if you have patients who are suicidal, I've had patients who are homicidal. I saw a patient once who their primary complaints were homicidal ideation and knee pain.
mhm,
So that was my role in that situation, but those are patients that we need to be concerned with. I've had patients come into the ED because they're suicidal due to their pain levels.
mhm,
So just like having conversations about how is this pain really impacting you, doing
mhm,
that PHQ2,
mhm,
screening for mental health issues so that you know how your patient's doing, just like vitals.
mhm,
You're going to monitor those mental health trends as well. So I
mhm.
would say that is another one where you don't want to mess around with that if patients are really struggling.
Yeah, so I usually on my intake form, I have the PHQ-4, which is two anxiety questions, two depression questions. And
Mhm.
then based on how I'm feeling with that patient, even if they respond a 0 to those questions, which 0 means they basically have no symptoms of depression or anxiety, even if they just write down nothing or if they don't have it on the intake form, if I get a sense that they are having some depressive symptoms or they give me some signs that lead me to believe that direction, I feel really strongly, and in fact, I spoke with a psychologist who recommended that you need to look the patient in the eye and ask them directly, "Are you having thoughts of killing yourself
Yep.
or harming anyone else or killing anyone else?" And they have to be able to respond to you directly with the confirmation of no. Um,
Mhm.
Otherwise, you need to now the second step to that was if they respond yes, that they are having thoughts of harming themselves, killing the and they she was very particular about using the word killing yourself, which I hate using that word because it makes me
Mhm.
uncomfortable.
Yes,
It should make anyone feel uncomfortable.
for
But
sure.
harming versus killing, she was saying that there were like, and I don't know this off the top of my head, but she was saying that from certain studies that using that phrase was more likely to really get to a patient that was having suicidal or homicidal
Mhm.
ideation. So the next step that she recommended was, if they do have that, ask about their family. Does anybody else know about this? Do you have a plan? And dialing 988 and getting that
Yes,
that hotline on the phone. And then based on their assessment, then they can help you decide if that patient either needs
perfect.
like
That's
some
even better.
consultation or needs to go to the emergency department because they are, it's
A
unpredictable what they may
danger.
or may not do.
Yeah.
Right.
So I would say if you're really not sure those resources fail you and that person is like a danger to themselves or others, I mean I would call their primary care doctors, but if they need to go to the emergency department, they need to go.
Mhm. Yeah, so I mean, we play a role in that, and I think that there are too many therapists out there that are, always wanting to pass off mental health
Yeah.
conditions to other providers, but we might be what they got, you know? Like, we
We
might
might
be the
be.
provider that they're seeing right now, and maybe their primary care, because I'm running into this more and more, their primary care doctors may or may not be accessible. And if their
Right.
primary care doctors are not accessible, when they call the office, the LPNs that answer the phone or that are talking to them are telling them to go to the ED for
Yeah.
XYZ
Because
but
there's
nobody
nowhere else
wants
to
to pay
go.
that bill if they don't think it's an actual emergency.
Yes.
So we need to take ownership of that and really recognize that we play a role in the continuum of care, for all body systems, not just for functional complaints that need our, continuous therapy services.
I think too
Um,
we're the when we develop therapeutic alliance with the patient,
mhm,
I think we're the best at that. I'm not gonna
mhm,
lie. Like of all the like medical professions, I think we are the best at that.
mhm,
And people will tell you things they haven't told anyone else.
mhm,
And those things come up when you have that like relationship with your patients. So we may be the only one they trust to give that
mhm.
information to, and we need to be responsible with that.
Absolutely. And I recall, when I was in the military, I had this one soldier. I mean, he was a first sergeant, so he'd been around for a while and had
Mm,
seen a while and had deployed multiple times. And he was very resistant to going to behavioral health. And and it's as much as it is getting better, it is still a stigma, and some people will just not go down that road. So if they see you continuously, what I did for this soldier, because I could tell that he wanted to tell me things, I just made sure that all of our sessions were in my room, with where, it wasn't in an open gym environment or anything.
yes.
And the things that he told me about his trauma, um, left me, I mean, the things that he described would leave anybody feeling like, how could you go on after
Yes.
experiencing that?
Yep.
But what I tried to do for the soldier was just create a space where he could talk and offload and tell me what he needed to do, because I knew that he wasn't like he told me multiple times he was not interested in going to behavioral health. But he said thank you after every session. He said, "I know this isn't related to my back pain, but thank you
But
for
is it?
listening." Exactly. I know, totally. But these were just his words, and, like, I think that that was, extremely healing for him. It was very helpful, and although, like, I wasn't doing any specific counseling related to those problems, I just created a space that opened it up so that he could talk, and I think that certainly was a part of his therapy experience, and I think that is
Hmm.
important that that we allow patients to do that, and that we understand and kind of know how to deal with patients that want to tell us about their
Yes.
trauma. I had the same
Hmm.
experience when I was at the cancer center, and some patients just want to talk about dying. You
Yeah.
know, there are patients that are going, some of your patients will die, and dying is a part of living. And they couldn't talk about dying with their loved ones and family members because they would be like, oh, you're so strong, you're going to beat this cancer.
Yes.
Their family members, it's like,
You'll never make it with that attitude. Yeah.
exactly, like it's too hard for the family and friends to allow them to talk about it
Yes.
oftentimes. So in any given circumstance, like if a patient wants to talk about something that's really difficult for them, that really can be part of their therapy experience. And
Hmm.
I think just knowing some basic strategies for how to empathetically listen to them and create a space, even though you're not going through like actual, cognitive behavioral therapy or acceptance and commitment therapy. I still think it's important for us to understand those types of therapy and be able to deal
Yes.
with patients in those situations. It's
I
really
agree.
hard.
Especially in the emergency department. Like I'll see
Yeah.
patients who have had failed suicide attempts, but now have fractured spines or
Right.
burns or whatever the case may be. So we are like trying to help those patients after that.
Mhm.
And then there are other times where we might be there when that patient makes the decision to go home on hospice from the emergency department. And we'll be making recommendations from that perspective as well.
Mhm.
And then we have patients who are there as a result of domestic violence or people we have to call adult protective services. There are so many psychosocial emotional pieces that go into providing care in a primary care setting or an emergency department setting,
Mhm.
and I think we don't do a very good job of preparing physical therapists for that.
Mhm. Yeah, and I think we need to do better. We need to do better all around with that. Man, I'm just sitting here thinking like what a powerful episode and conversation this has been. First of all, kind of dispelling some common beliefs about what actually needs to go to the emergency department. And maybe this is the impetus for some papers that need to be drafted about how we address quote unquote red flags. And
Yes.
sometimes oftentimes these red flag findings are not emergent. They
They're
can
not.
be managed in the outpatient setting, and they can
Yes.
probably be managed better.
Yeah,
So,
100%. Because if they
mhm,
come into the emergency department, we'll tell them this is not an emergency and send them home. And then that patient's like, oh, it's not an emergency. And then maybe they don't follow up.
yeah.
But I would say my disclaimer is just that when in doubt, like if you don't know and you're not sure, please just still send those
Mhm,
patients. We will take very good care of them.
mhm,
But just like in developing your practice and becoming more mindful and like thinking about how to be that primary care manager of those patients. What can you manage? What can you manage outside of the emergency department? How can
mhm,
you help us triage patients to keep them in their homes? It's better for them and provide the best care that we can, especially in the face of serious access to healthcare
yeah,
issues.
absolutely. Well, this has been awesome. I feel like we could continue talking for hours about this, but
Probably.
just to wrap it up, what are so tell us a little bit about your book, where people can find your book, your
Sure.
website, your stuff that you got. How can people get all the good things from you?
So the book is called Top of Scope, an emergency physical therapist handbook. And the purpose of the concept of top of scope is really using everything that you have, your training in physical therapy school, your clinical rotations, your clinical experience, your personal life experience, all the continuing education that you've had, your teammates, all of that, and really practicing at the highest level that you possibly can. Obviously, we're limited by practice acts that are different in different states, facility guidelines, all of those things, but taking everything you can and like practicing at that high level to help move our profession forward and to help support our patients, because we are the right provider in so many cases and we need to act like it and we need to own that.
Yeah.
So this book really focuses on how to help you start a thriving emergency department physical therapist practice. If you already have one, it will still help you. If you're just looking at making a quality improvement initiative in a hospital or a clinic setting, I think this book will still help you because it takes the emergency department as an example, but you can use the blueprint to apply to really any initiative that you want. So you can find that on Amazon, Top of Scope. And also, we have another course. We're going to do another 2-day course on starting a thriving practice in the emergency department in Boston this September.
Awesome. That's great. And you can find that at the eddpt.com. You can also find Rebekah. Where on social media are you, Rebekah?
At the ED DPT, Instagram, Twitter, Facebook, all of those things.
Awesome. Thank you so much.
Oh, you're so
I'll put
welcome.
I'll put all her social media handles and references and different things like that in the show notes if people want to access that. But I'm so excited for you. You've made, I mean, I'm so proud of you. I am like, you are just a shining light and such an example for women in our profession, women mommies too.
Yes.
You're a mom, I'm a mom. We're both just breaking and, making waves in our respective areas. And I just feel like we're kindred spirits, and I couldn't be more proud and excited for you.
Thank you so much. I appreciate it.
Thanks for listening to the Redefine Health Ed podcast. Support our mission of getting more rehab professionals integrated into primary care by visiting redefinehealthed.com, subscribing to our email list, following us on social media at Redefine Health Ed, and taking one of our courses. All podcast listeners can save $50 on our Foundations for the Primary Care Therapist course or the Master Musculoskeletal Imaging certification by entering RHE Podcast, all lowercase, into the promo code section of the checkout page. Until the next episode, stay awesome, y'all.